Okay, 7:05. I think we can get started. It sounds like a couple people have an issue with the link, which we're going to work on. Um, MJ is going to talk this morning on a couple things, but starting off with a trip to Bolivia that was recently done. And I don't know how many of you know about this, but it's kind of an ongoing effort that has mainly been spearheaded by Hutch. Angela was recently down there, however, also, and it's something we've tried to develop in recent years. We've had a couple different people go down, most recently MJ. And so I'm excited to hear about what you have to say about your trip, MJ, and take it away.
Awesome. Thanks, Dr. Tischer. So, hi, everyone. My name is Miranda. MJ. I'm one of the PGY5s. I wanted to talk about my recent trip to Bolivia today, as well as another topic quickly at the end of my presentation, but we'll start with Bolivia. So as some of you know, I went to Bolivia for several weeks in November. I'll start with a discussion about that trip and then provide some additional insight into the medical system in the country, as well as the ethical implications of short-term surgical missions. My first thought upon arriving in Bolivia was that it was a very, very different place to be a doctor. On top of that, being the only hand fellowship trained surgeon in the entire country is another thing entirely. So on the right there, you see Dr. Jorge Terrazas next to Dr. Wong. Dr. Terrazas was our host during the trip, and Dr. Wong was the team leader for the American group. So getting into the trip itself, we started in Salt Lake City, and with a series of transfers, we gradually made our way to Bolivia, landing in Santa Cruz and then hopping on a much smaller plane to Tarija. Tarija was founded in 1574. It's in southern Bolivia at elevation, though it's not the highest city in the country. It's bisected by a large river, and their wine production is actually the #1 economic activity in that community. The seventh largest city in Bolivia is Tarija. The largest is Santa Cruz de la Sierra. And you cannot find alpacas here, something that really disappointed me because I was looking for them everywhere. Bolivia is actually the poorest country in South America. So we spent all of our time in the San Juan de Dios Hospital working with SOS Mano Foundation, which is run by Dr. Terrazas. About 20 years ago, Dr. Hutchinson was participating in an outreach trip in Bolivia when he heard of him. And Dr. Terrazas is the only formally trained hand surgeon in Bolivia. He serves a country with a population over 10 million. He had been hosting outside groups for years, working with them to provide much needed hand services to underprivileged population in the country. At least a third of Bolivians live in poverty, and government-sponsored healthcare is not provided until the age is 65. So as a result, access to appropriate treatment for even the most basic stuff is very limited. Dr. Hutchinson and Dr. Terrazas formed a relationship and a friendship that lasts to this day. The conditions managed by the foundation include congenital hand conditions like thumb duplication and syndactyly, as well as traumatic injuries. We saw a lot of burn contractures and tendon injuries. And the goals of the procedures are to optimize and increase the function of the patients. We spent our first day in clinic. So patients filed into the hospital and were waiting for us, kind of lining the hallways. The foundation advertises on television and radio, so many patients know that we are arriving beforehand. But once the foundation is at the hospital, word of mouth spreads the information further, and patients trickle in and show up intermittently during the week, and they just wait all day long to be seen. Dr. Terrazas and Dr. Wong held clinic visits together and saw each patient as a group. This ended up being a very useful decision because while Dr. Wong speaks really good Spanish, there's a lot of subtleties to the conversations between surgeon and patient, and even more importantly, between the surgeon and the patient's families that require fluent Spanish. Most patients were pediatric and were accompanied by multiple people who had made it possible for them to be there in the first place. And we saw about 50 plus patients in clinic, and we indicated over 50% of them for surgery. After they finished with us, they were seen by occupational therapy if they needed a brace or conservative treatment, and by our anesthesia team if they were indicated for surgery. Some of them required ultrasounds, and our anesthesiologist had a handheld butterfly ultrasound that hooked up to her phone. So she was able to perform those pretty quickly in clinic. The Bolivian team had a paper-based method for recording patients' plan for surgery. They took pictures of everyone's hands and faces to allow the connection between the patients and the surgical plans in the days to come. Because as you can imagine, you're seeing just a large number of patients back to back, and you had to be really careful that you had all their information kind of gathered together. We saw a wide variety of really interesting cases, including neglected trauma, such as elbow dislocations, olecranon fractures, and finger dislocations. We also saw a number of congenital deformities, syndactylies, and burn contractures. Some of these patients had been traveling around the world and really around the country and in adjacent countries trying to get their issues managed. With one 18-year-old male with a thumb deformity seen in the bottom right image, having waited his entire life to have that addressed. His mother actually brought that patient along with his younger brother who had an EPL tendon rupture to be evaluated in together. The persistence of these families and really the persistence of the parents in getting their patients care and their children care is really amazing. Some of the cases we saw were really fascinating and complex. Some of the residents here had seen this picture before the trip to Bolivia, and as a team, our mission trip had reached out to the infectious disease service in Utah before going to see this child because we really didn't know what the major issue was here, if it was infection or something else. When we met him and his family in clinic, we determined that he had ichthyosis in the setting of cleft hand. And so ultimately, we determined that surgically there was nothing we could do to drastically change this deformity with his overlying skin issues. And we recommended bracing to allow his family to manage the persistent wounds that were forming between his fingers. The decision was based on the desire to avoid causing more harm than benefit for this patient, which was a big part of every decision we made for patients. For the rest of the week, we were in the operating room. We were very fortunate to have 2 dedicated operating rooms that allowed us to work in tandem, and we had sufficient surgical staff for that. So the Bolivian team had brought basically everything into the hospital to allow for a functioning operating room. All they needed provided from the hospital was the tables, the OR lighting, and some staff from the hospital to assist as circulators and with turning rooms over. They also brought several residents in training, which gave us a number of team members that could help at various steps in the process. Our occupational therapist, Andrew, was able to provide splints and braces that were custom made for the patients in the operating room using thermoplast material that he heated up, and then it would kind of cool and mold to patients. The first few days, we were very much figuring out the rhythm of our teams and learning how to use new protocols and equipment. And for example, our anesthesiologist informed us that the anesthesia machine was, quote, not a scavenging system like she uses in the US, which is something that was totally new to me, but basically that the excessive isoflurane gas that was being emitted was not being recycled and controlled by the machine. So at times we would get a whiff of this gas and we just open up the window in the operating room a bit wider, which honestly was necessary anyways, because our first few days, the operating rooms were so hot and the air conditioner would turn off about every 2 minutes and you have to turn it back on again. There were several patients that were really emotional to work with simply based on the amount that they'd been through. The prevalence of burns and burn contractures was very high. So many patients have been burned as children and were dealing with the sequela of those injuries. The patient that stuck the most with me was this, and I know with other people as well in our group, was this young female. She'd sustained burns in her hands, her face, and her neck, resulting in a hand contracture that we addressed early in the week when we got there. However, during her care, all of us noticed her neck contracture because it pulled her lip down, it exposed her teeth, and it really tethered her chin down to her chest. And she had to look up at you from a very awkward position. She didn't really have a horizontal gaze. Initially, we were very worried about her airway, but the anesthesiologist working with us evaluated her very closely and ultimately felt that the tissues of her neck were soft and anticipated that her airway would not be that concerning or hard to address. So as a team, we were like fixing her hand, but also thinking to ourselves, wow, that neck is really a problem that she has to deal with. And it's a major limitation for her function. Ultimately, we decided we wanted to address her neck as well as her hand after a big team discussion. And she returned to the operating room several days later for neck contracture release and full thickness skin grafting. Our occupational therapist, who was truly amazing, he was fluent in Spanish and just was such a hardworking person. He made a custom cervical collar for her. And it was amazing how different she looked after surgery. Her mouth was able to function more normally. Her lip was kind of closed over her teeth. Just sitting in the pack, we could see that her mouth was closing and she had a chin. We're still following her course as she's requiring some additional surgery since that time to assist with the healing of mostly her hand, but somewhat her neck as well. She's got some granulation tissue there, but we're very grateful that we have not only a surgeon providing consistent follow-up for our mutual patients, but regular contact with that surgeon because it allows our whole team to stay engaged with the work we did in Bolivia and learn from the decisions we made there, which is perhaps the most important part. So I'd like to touch base a little bit about what it's like to practice medicine in Bolivia, and because it provides a setting for a recent mission there. So doctors in Bolivia interact with the medical system and the government in ways that American doctors really don't. So the medical community has been in strikes numerous times. In 2018, healthcare workers across the country participated in strikes aimed at reversing a proposed law that would mean doctors found guilty of malpractice would not only lose their license, but liable for compensation payments and have been imprisoned for up to 4 years if there was serious harm and 6 years if the patient died. The Secretary General of the World Medical Association made a statement around the time of this law saying that having criminal sanctions for medical error is harmful because doctors become reluctant to treat high-risk cases. It makes it difficult for them to learn from their mistakes because people do not want to admit error. And in developing countries, punitive laws actually encourage doctors to immigrate out in search of better working conditions. And then most recently, there was a strike in September 2021, and that was in an effort for the doctors to force coronavirus lockdown in Santa Cruz. So the doctors in Bolivia are much more politically engaged, and they're frequently interact with the government in order to control changes that they feel will negatively impact their field. And these strikes are not passive. They are active riots, and they're a loss of life in the process of advocating for change. Given that Bolivia is one of the poorest South American countries, it has unique challenges. Some of the government's profitability in the past has come from illegal drug trafficking, and efforts to control and eradicate the use of mainly coca crops has produced economic depression in the country. Only about 35% of patients are traditionally employed and receive wages from a company. Many live as street vendors. The average life expectancy for a Bolivian is 53 years, which is the lowest in South America. Traditional medicine has a large role that was emphasized by a recent president, and it has resulted in what is known as the plurinational healthcare revolution. So this revolution is known for its inclusion of more traditional medicine, which makes it more inclusive for Bolivians that identify as a member of indigenous groups. This is really common. About 40% of Bolivians identify as one of almost 40 indigenous groups. So under the Evo Morales administration, indigenous healthcare beliefs and practices returned to the more mainstream medicine. Indigenous populations and social movements, as well as coca growers, all propelled him into his democratic election. And many consider the plurinational revolution to have started with him being elected. He also announced a bunch of different paradigm shifts in terms of how they structure the healthcare system that was really trying to decolonize what they view as an unequal public healthcare and a medical system dominated by Western biomedical perspectives and practices. And then in 2009, the Bolivian government established a vice ministry of traditional medicine and interculturality, and then ordered the creation of these similar bodies all over for different countries' departmental and municipal governments. And then in 2013, they enacted a law based on traditional Bolivian ancestral medicine. And during his presidency, Morales really embraced the indigenous culture and symbols and ramped up the plurinational healthcare revolution. He and his political entourage eventually resigned in November 2019 and left the country in the setting of mass protests and military pressure, given a disputed election. So he was thought to represent the peasant and indigenous parts of the Bolivian society, and his departure was followed by periods of unrest and political clash. It was felt that he was illegitimately taking a fourth term and negatively impacting the middle class. But however, like during his time, he decreased the number of people in poverty from 38 to 18%. So he was definitely impacting that lower bottom line for those people. Since he left, the traditional medicine does not quite have the support it had under his regime, but it certainly remains something that's important in the country and all over the place. The picture here shows the witches market in La Paz. So Morales did impact the practice of traditional medicine throughout the country. Bolivia, before that, legally recognized indigenous medicine in 1985. And that just meant that providers who were providing that service no longer faced imprisonment for practicing traditional methods. Under Morales, the Vice Ministry of Intercultural Health certified more than 5,000 indigenous naturopaths, herbalists, and midwives. And most revolutionary is the indigenous medicine and practices actually entered the national healthcare system. So today, traditional healers are actually contracted to work in public clinics and hospitals across Bolivia, particularly in rural areas where providers are limited. There's also traditional medical centers that have opened, and Bolivia's second largest city has one of those medical centers where more than 8 in 10 people are indigenous. So these advances were unfathomable prior to Morales' presidency, and in some degree have lessened and been replaced with his recent new presidents that have followed him. So that leads us to the intersection of traditional medicine and COVID. So ultimately, the use of traditional medicine became rampant during the pandemic. Bolivians utilized coca leaves, eucalyptus, and indigenous herbs native to South America, just trying to ward off the coronavirus. Early on in the pandemic, senators approved a motion that promoted the use of traditional medicine, which has long played a role for the indigenous communities. In March of 2020, the Deputy Minister for Traditional Medicine made the following statement. He said, "The message that we want to give the Bolivian population is to take up consumption of traditional medicine, because this strengthens the immune system and prevents against a variety of illnesses, especially coronavirus." In April of 2020, the Vice Ministry of Traditional Medicine and Interculturality installed what they called disinfection booths. And these booths were little individual cubicles in which a patient was sprayed with eucalyptus, chamomile, and vera vera vapors for about 3 to 5 seconds. And while it sounds very relaxing, the results were obviously ultimately questioned and were unlikely to help against the coronavirus. Later in 2020, the healthcare system largely collapsed under the pandemic, but the demand for medicinal herbs continued to soar. And this included branching out into different substances. So in the second half of 2020, patients were found waiting in line for chlorine dioxide, which is a type of bleach used to disinfect swimming pools and floors. The use of the chemical was espoused by local soccer players and famous individuals in position of power. Many people were hospitalized for ingesting the material. The government actually tested it on prison inmates, and the National Senate in Bolivia approved its use. A top lawmaker threatened to expel the World Health Organization for opposing its medicinal use. Bolivia and Latin America in general were one of the worst hit by the pandemic, and Bolivia was not alone in trying to protect its people this way. Peru purchased large amounts of ivermectin and continued to promote it after the WHO said it should not be used. And Brazilian leadership was similar. However, the United States found its own leader promoting ivermectin, powerful lights, and disinfectant injections. And as of several days ago, there have been almost 600,000 infections and 20,000 coronavirus-related deaths in the country since the pandemic began. They've administered only enough vaccine to have vaccinated roughly 40% of the population. This has a big impact on a country that struggles with poverty and now is struggling with Omicron. In comparison, the US has seen about 52 million infections and over 800,000 deaths associated with COVID. And we have a vaccination rate of 76% when I checked Reuters a couple days ago. And finally, I'd like to round out this presentation with a discussion about international medicine and the ethics that pertain to it. So 1/3 of the global burden of disease encompasses surgery. And 1/3 of the world's population lives in low and middle income countries. So as the population grows and longevity increases in the world's poorest countries, the need for surgical services is estimated to increase by really an insurmountable proportions. It is estimated about 143 million additional surgical procedures will be needed in low and middle income countries. And furthermore, it's estimated that 1.4 million deaths could be avoided yearly with basic surgical procedures. The Global Surgery Commission released a report called Global Surgery 2030, which highlights that the poorest sector of the population only receives about 3.5% of all surgical procedures. So reasons for this disparity are numerous. It includes poverty, physician shortages, and infrastructural challenges. To combat this disparity, short-term surgical missions have really increased, and these are led by non-governmental organizations, private organizations, and academic institutions, with the goal of providing much-needed surgical care. And this is especially true for hand surgery, given the direct link of hand injuries and anomalies with productivity. In recent decades, much of the effort has gone into protective strategies for research subjects, given the potential exploitative nature of research. These same protections for patients who are cared for as part of humanitarian missions are largely non-existent, despite the fact that humanitarian missions can also be an unequal relationship. In 1997, the Institute of Medicine published a report on America's vital interest in global health and said that in the pursuit of well-being, especially for the most vulnerable, we must hold ourselves to the same standards as we would if we were treating a family member and not betray the trust that the patients place in us. Practice patterns should be universally applicable and based on a standard set of ethical guidelines, as opposed to conforming to what is perceived as acceptable in a certain setting. So when you show up in a new place, you think, well, maybe this is okay here. No, they really want you to hold yourself to the standards you would if you were in your home country. And so really the same ethical principles that dictate care in the US also apply abroad. So the first important principle is autonomy. Patients have the autonomy to decide what procedures they allow performed and must understand the risks, benefits, and alternatives. There are nuanced barriers in low-income settings, and patients may even rely on the head of family or community leaders to make decisions in their best interest. This may be amplified in medical mission trips where patients may perceive foreign doctors as having authority. This also pertains to trainees, including myself, who are often afforded operative opportunities that are not necessarily available in the magnitude, diversity, or the level of autonomy that can be seen by trainees in the global setting. It's crucial that this sense of responsibility is not misplaced and that trainees be held to the same or even higher standards on an international surgical mission as they would be at their home institution. The Working Group on Ethics Guidelines for Global Health Training developed guidelines for trainees to avoid ethical breaches. They specifically recommend adequate mentorship and supervision and provide framework for strengthening global health partnerships. DeCamp et al. Publish ethics curriculums for short-term global health trainees, and that aims at increasing awareness of ethical issues in global health. So there is evidence that in-country trainees also question the ethics of visiting surgeons. So a study on perspectives from trainees in Africa revealed that 31% of trainees were uncomfortable with the ethics of some clinical decisions made by visiting faculty, and 40% felt international groups had a neutral or negative impact on patient care. The next major ethical principles include beneficence and non-maleficence. So Beneficence is to do good, or non-maleficence is to do no harm. So these principles often work in parallel. We are naturally drawn to wanting to help others, and therefore many of us are naturally drawn to short-term missions. This principle is often best displayed in the setting of surgeons attempting to address really complex problems like congenital deformities without a follow-up plan in place or a way to monitor for and address complications that the surgeons and providers in the community did not know how to diagnose or even treat themselves. Moreover, certain complications may not be solvable depending on a country's resources. So accountability can be compromised in that setting. Instead, there's this body count mentality that can prevail, where a team strives to do as many operations as possible with little to no regard for the outcomes. And this represents prioritization of quantity over quality. It's estimated that 5.7 to 8.4 million deaths in low income and middle income countries are attributed to receiving poor quality care. 2.1 million of these deaths are attributed to deaths in the postoperative period. So with no accountability and follow-up, morbidity and mortality are unknown, and a very well-intentioned surgical mission trip can result in extra burden for the patient and the healthcare system. Another problem in the preceding scenario is that the surgical team that's visiting is operating with limited resources, which has the potential to compromise the quality of an operation if the team is operating in modified ways that are unfamiliar to them. And the unintended consequence of harm can prevail in that setting. The solution is not to bring in the familiar healthcare equipment you need. It's not to say, well, I really want my tools and supplies, so I'm going to bring everything over with me rather than working well with what's supplied and available. And the World Health Organization supports this notion and reports that if donations are made without planning and collaboration with the receiving healthcare system, they can be very burdensome to those receiving them. So a volunteer surgeon must be sufficient in skill to adapt to the limited resource setting and perhaps even learn from the local surgeons how to make do with what they have while achieving acceptable outcomes. So integrating the home-based surgeons and physicians is really important. It's essential to the mission. So there have been calls for international morbidity and mortality conferences as a method of maintaining accountability. And an example of effective record keeping is actually from Operation Smile, where they made an EMR system which is dedicated to evaluating and reporting perioperative complications. And our recent trip, we have continued conversations with the team both before and since our departure. We received updates and pictures of every patient we operated on. The supplies we brought with us were brought after discussions with the team about what they needed and with the knowledge of what has helped them in the past. And the key to this is really the surgeon who hosted us and that team and the active collaboration between our two teams without the exclusion of the whole home team, because obviously they know the most about the situations we were operating in. Finally, we come to the topic of justice. Justice in medical health is fairness, really. It includes three aspects. There's distributive justice, rights-based justice, and legal justice. Distributive justice relates to resource allocation. It's especially important in low resource settings. Rights-based justice is respect for an individual's rights, and then legal justice is respect for morally acceptable laws. In resource-limited countries, the decision on provision of care for surgical ailments must be made while considering other needs in the country. So short-term surgical mission trips should not create competition for resources that are already scarce. And this includes basic things like power supply, which is something we worried about. You can short the power to whole parts of the building if you plug the wrong thing in. And it also goes up to larger, higher levels of competition, like taking an operating room from another team that also has patients waiting for care. So during our most recent trip, we brought the supplies that would enhance our mission. The Bolivian team brought literally everything that the operating room didn't have bolted down to the wall or floors. We did not rely on the hospital for supplies. We did, however, utilize the help of medical staff in the hospital in coordinating patients getting to and from the operating room, as well as the operating process itself. And this man labor is certainly very valuable. The last topic that's worth discussing is the concept of poverty porn. And you may be familiar with commercials that are often occur around the holidays, showing destitute children in terrible situations. Some of us are triggered by Celine Dion's animal commercials. All of these are examples of using difficult imagery capturing a person or a being at a specific moment in time that's deemed to need our help, often in a financial way. The concern is that photographers, charities, and non-governmental organizations exploit the situations of patients and people in dire need. Some argue that displaying the worst case scenario inspires people to do something about them, and that in theory can result in people receiving help. There's also the argument that these images empower the wrong person and present a one-dimensional representation of poverty and what contributes to it, and can dehumanize the people who are actually in that situation. Regardless, there's a reason that humanitarian aid organizations often use it. It works. Donations have been shown to be higher when people are shown in suffering rather than being shown prospering. And I find the quote by author Chimamanda to be very relevant. She says, "The problem with stereotypes is not that they are untrue, but that they're incomplete. They make one story become the only story." So despite limitations of short-term surgical missions, including their short duration and lack of long-term collaboration, establishing a continuous long-term relationship can be the key to transcending these limitations. So long-term collaborations facilitate training, education, and can help establish and build trust. After my trip to Bolivia, several principles are worth emphasizing. Surgeons from the country are immensely invaluable. They often hold the key to being the most effective team in that particular environment, and they also assist with follow-up after you leave. They can teach you about things and ways to navigate surgical pathologies that you've not seen before. Setting up a long-term relationship allows for the teams to become more and more effective over time. So we noticed that in our own group. The first few days of the trip were much less coordinated, but as each day passed, we became a better team to the point where it was so smooth by the last few days and so much fun because we all just knew what to expect and how to help each other to move forward towards the goal. And at the end of the day, we're just human beings trying to care for human beings, and it's a privilege to do that out of our own country. So a quick summary. For me, this was the type of trip that changed a lot of things that are really hard to describe. It was deeply emotional at points. It left me feeling more like a doctor than I felt in a really long time. There were scary moments and a ton of personal growth. I came back really grateful. There are truly is a universal language in the operating room that everyone ends up speaking. It's partly body language. It's partly mutual understanding of the next needed step. Either way, being a part of that flow is an amazing thing. This trip will impact how I think about and account for underserved populations in my future practice. And for me, I'm hoping to return to Maine eventually. This includes commercial fishermen, lumberjacks. There are seasonal blueberry farmers that come during the summer, and there are a large number of Somali refugees that have joined my state over the recent years. And if you take one thing away from this talk, it should be that success in these settings really does require a team and long-term follow-up. Without that insight into your outcomes and how you impact patients, the trip isn't worth it. You need to know that the people you leave behind are taken care of, and if what you did was effective. And most importantly, there is something to be learned from literally everyone around you on those trips. So I just wanted to say a huge thank you to Dr. Hutchinson and Trudy, who helped me get abroad when I didn't think this opportunity would happen this year, and also to both the Bolivian and American teams that went on this trip and made it so much fun. And finally to Louise, who suffered for me at the VA while I was gone. And then any questions, I'd love to answer them at this point.
MJ, thank you. That was really interesting. As a hand surgeon or budding hand surgeon, you're going to be able to do this kind of thing in the future, as much or as little as you want to, depending on your choices. What do you see your future as in the realm of international work, or what are your thoughts there?
Yeah, I know that I want to be involved now. I think that there's a couple major things that I came away with from this trip. One was me wanting to find a way to integrate those populations that are from lower income areas wherever I practice. But the second thing is that I definitely want to go abroad again. And I think the biggest mission and the biggest lesson to be learned here is that the group you choose to go with is crucial. So if there's not a follow-up system in place, and if there's not a well-structured group, I don't know that you help as many people as you think you do. And so going with Hutch and going with Dr. Terrazas and the whole team there, it's a well-oiled machine, and we can really impact people's lives. And so I think down the road, when I'm in practice, I would be looking for a similar group to go with, just to make sure I maximize the time and I'm actually benefiting the community I'm with.
Yeah, I think that's an important point. Pelt, you have a question or comment?
I was just going to say, for joint replacement, our Hip and Knee Association, AUKUS, has taken on one sort of charitable mission organization in Operation Walk, and that's become the sort of only, maybe not the only one, but the primary mission for our professional organization. Is that true for most other subspecialties in orthopedics or other surgical specialties, or is it just everybody's finding their own sort of place to go?
For hand, it seems like there are a number of different ways you can get down there. I know Dr. Terrazas works with people from Spain. There's several groups that go with him. So I don't know. I mean, there are multiple groups that go for hand. I don't think they have, the specialty has kind of winnowed it down to one major group. I don't know, Dr. Tischer, Dr. Wong, Dr. Hutch, do you guys can you speak to if there's a more centralized group that hand goes with?
Yeah, so it's a little bit haphazard in the hand world. However, there was a relatively recent initiative by Scott Kozin, one of our ASSH presidents, about 3 years ago, I think, to develop an ASSH society-based organizational structure for these kinds of trips called Touching Hands. As far as I can tell, it's still kind of a loose framework for organizing things, but that has been the effort with that within our society. I think it's still pretty all over the map, literally.
I mean, just to plug UofWalk, you mentioned Operation Smile, Jay, and I don't know if you know the background. The people that founded that are actually connected to us here at the university, and Trevor McGee was one of our fellows, and his parents started UofWalk, still do, and Operation Smile, Operation Walk was an offshoot from Dr. Larry Dorr, who's now since passed, and his kind of relationship with them, as well as Aaron Hoffman's relationship. And the things that you mentioned about international medicine and the outreach and the follow-up and the education and the connectedness to the team that lives there, as opposed to just swooping in and swooping out, I think are all really important. And UofWalk provides a little bit of that foundation. You can start your own chapters, but you have to have this foundation of education of the local team. We bring them back to the U.S. to do observation and education and training. They work with us there to organize and see the patients both before and after and follow up, and are connected through the different chapters where they might serve maybe different countries where each chapter chooses to go. But the framework is kind of established by the Operation Walk Foundation, which has been really beneficial, I think.
Awesome. Yeah, that makes a lot of sense. And the highly organized groups clearly have it figured out, and they provide a better standard of care, I think.
Yeah, I think, the points you brought up, MJ, are really good to think about, especially at the end of that talk. And, I think most people, or many people, think that these trips are just a, foregone conclusion that they are a huge benefit. And I think in many cases that can be true, but as you may have found out on this trip or in researching this talk, it sometimes is a little bit more complicated than that. You mentioned, a certain relatively high percentage of trainees in other countries that have felt like maybe this was a neutral or net negative experience for the people involved. And there's, many of you may know about this, but there's a relatively new kind of ethical framework for thinking about not only this, but philanthropy at large, which is called the effective altruism movement. And it's really interesting. It applies kind of return on investment kind of principles from business to philanthropy. And for those of you who are interested or thinking about going on trips like this, one book that I've found very informative is something called Doing Good Better. It's relatively short, it's relatively easy to read, but it kind of illustrates some of the issues that I think you were kind of touching at, Miranda, which is, I think, important and critical to think about when you're involved in medical missions.
Totally agree. And I think that was the thing that I kept mulling over when I came back. It was overwhelming amount of travel and overwhelming amount of stuff that we did. And so I was exhausted when I came back, but the stuff that started to kind of come, I dwelled on when I got back was exactly that. Like, how much good did we do? Are the patients I operated on okay? Like, and seeing their pictures and having that actual feedback was crucial. But I had this kind of anxiety about the people I'd left behind and the decisions we'd made there. And I know a lot of us felt that way. We're like, I hope they're okay. And every time those pictures were sent to us by the group from Bolivia, we were like poring over the pictures and making sure that the wounds looked okay. And I think that's good. I think you need to have that that self criticism and that ability to recognize that what you did for somebody hopefully is really great, but if it goes sideways, can really also be terrible and want to find ways to deliver care the best way you can.
Thank you. Any other thoughts on this topic before we move on to the second part of this hour? Thanks again, MJ. That was a great summary, and I like the framework that you fitted into.
Awesome. Okay, so I'm going to quickly move to a different topic. This is something I wanted to go over just because of a patient that I'd interacted with, but try to not spend too much time on compartment syndrome because I believe Dylan will be covering this more exhaustively for his presentation. So I'll be talking about missed or chronic compartment syndrome. So I'll start with a case and then move through the interventions and close the case so you can figure out what happened to who we took care of. So You receive a page from the ED about concern for compartment syndrome. So given that they send a lot of these pages, your first thought is that it's unlikely to be the true issue, but you go hustle down to the ED anyways. And there you find a 17-year-old male in the company of his father who's driven him from Nevada to your ED after being sent home from 2 emergency departments out there. The patient was hit in the anterolateral leg 5 days ago during a football game. At the time of his injury, he was able to walk but had substantial pain. 2 trips to the ED revealed negative radiographs, and the patient was sent home despite worsening pain, weakness, and numbness in his right leg and foot. He tells you he's been unable to move or feel his foot for about 24 hours after the injury, and your exam finds no motor function below the knee except extension of toes 2 through 4, lack of sensation, and a biphasic pulse. His anterior lateral compartment is full and tense, and his posterior compartment is still tense as well. His foot is resting in a equinus position, and the patient appears comfortable at rest. However, with passive range of motion of his foot, he has notable pain. He reports that immediately after his injury, he was very much not comfortable in any position, no matter what he did and no matter what pain medication he was taking. And this has gradually improved as the days have gone on, however. And this is a picture of his actual leg when we saw him in the ED. His relevant labs are listed there. He was found to have a mild leukocytosis, normal kidney function and electrolytes, a creatinine kinase level of 14,000. Of note, his serum CK begins to rise within 2 to 12 hours of onset of muscle injury. It reaches maximum peak within 24 to 72 hours, and the decline is usually seen within 3 to 5 days of cessation of the injury. CK serum half-life is approximately 1.5 days, and it declines at a rate of 40 to 50% of the prior day's value. Radiographs in our ED revealed no osseous injury and no obvious sign of knee or ankle dislocation. And then here we have his MRIs. See a lot of edema, especially in that proximal aspect, anterior lateral compartment. And then we have axial MRIs here. So the MRI read actually reported extensive fluid edema and enhancement throughout the anterior and lateral compartment musculature, especially proximally, but also involving the deep posterior compartment. They noted patchy areas of central intramuscular non-enhancement involving the anterior lateral compartments and to a lesser extent the deep posterior compartment that were favored to represent myonecrosis. And they noted a diminutive appearance and high-grade narrowing of the anterior tibial artery that was secondary to extrinsic compression from the fluid and edema. The MRI read itself stated verbatim, findings are consistent with late sequela of clinically reported subacute compartment syndrome with multifocal regions of myonecrosis. So after discussing the case with Dr. Rothberg, who was on call with the trauma team at the time, we eventually provided ketamine sedation to allow splinting of his leg in a better position because we didn't want it to stay in equinus for long. We also sent him home with both Lyrica and Mendrol dose pack. Ultimately, the most important part of the treatment centered on a frank discussion with the patient and his father about our concerns for subacute to chronic compartment syndrome and our decision not to recommend surgery at the time. The combination of his delayed presentation and the myonecrosis on MRI made us concerned for muscle necrosis that would result in unsuccessful fasciotomies that ultimately set him at higher risk for infection and other complications, including amputation. We also spent significant time discussing that we would not definitively be able to prognosticate about his return to function and the timeline for recovery if they were to occur at all. So now we'll focus a bit on chronic compartment syndrome, otherwise known as missed compartment syndrome. So as we know, compartment syndrome is caused by an increase in intercompartmental pressure within a fascial envelope that ultimately leads to impacted tissue perfusion. The etiologies are vast. It's vascular ischemia and reperfusion, trauma, venous outflow obstruction, cross injury, hemorrhage, fracture, and more. The unifying feature of all compartment syndromes, regardless of what causes them or where they're located, is that increase in intercompartmental pressure within that unyielding fascial envelope. So as the pressure rises, it can be transmitted to the postscapular venules, increases the venous pressure and decreases the arterial venous pressure gradient. And furthermore, increased intercompartmental pressures may collapse capillaries and decrease their radius, further increasing resistance to flow. Mattson et al. Suggested that there is a critical closing pressure above which capillaries collapse from transmural pressure and blood flow is arrested. His studies have been questioned by others who've sought to define the threshold for that intercompartmental pressure that produces tissue injury and cell death. And Harkins et al. Found that an absolute pressure of 30 millimeters of mercury for 8 hours universally produce muscle necrosis in normal tensive dogs, whereas pressure less than 30 produce no muscle necrosis. And tissues do differ in their susceptibility to increased pressure. So early signs of endoneural injury were observed at pressures of about 30 for 8 hours. The differential susceptibility to injury between the tissues may provide an explanation for cases in which delayed fasciotomies fail to restore neurologic function, even though the muscle looks viable in the compartment. The available literature on miscompartment syndrome is very limited and mainly consists of retrospective case reports or series. Prospective randomized trials would really be ethically inconceivable around this topic. Nonetheless, the available literature does suggest that in certain situations, a miscompartment syndrome that has evolved past acute injury phase may be treated non-operatively in certain patients. A reasonable way to think about these patients is to first determine how long the ischemia has been present by obtaining specific history to that end, as well as how much damage you think has occurred. So the latter question is what drove our decision to get the MRI imaging with the football player in order to better understand the degree of myonecrosis present and to have some idea of how injured his muscles were 5 days out from injury. In 2016, Glass et al. Performed a systematic review of the limited literature regarding lower extremity compartment syndrome that was missed. They identified 9 studies that comprised 57 patients with missed compartment syndrome. They ultimately graded these studies as either low or very low quality. All but 1 patient in these reported series had an emergent fasciotomy, and the subsequent amputation rate was alarming. They summarized that of the 63 limbs in the 56 patients that had surgery, 21 amputations were eventually required and 2 people died. The authors describe the decision to perform emergent fasciotomy in the cases of missed compartment syndrome as an act that, quote, commits the surgeon to an amputation should the extent of muscle necrosis be unfavorable. They also looked within their own facility, and they found 10 cases of missed compartment syndrome. They managed 6 patients surgically, had worse outcomes, and then 4 were managed non-surgically. In this research, Glass et al. Stated that ischemic damage depends on the magnitude of pressure, the muscle mass, metabolic requirements, and the duration of delay. It does not correlate linearly with the pathologic sequelae observed. They felt that surgeons should evaluate carefully the patient and monitor for signs and symptoms of sepsis or renal injury from evolving necrosis in the compartments. He felt if there was concern that the load from the ischemic damage is beyond the level that can be lead to a satisfactory outcome without surgery, the surgeon should immediately consider performing a fasciotomy, understanding that the decision could lead to amputation. And his point was that you obviously do not want someone to go into complete renal failure in the setting of a limb that is dying. The authors also stated that the decision to monitor miscompartment syndrome in lieu of fasciotomy should really only be considered in the lower extremity. They advocated that miscompartment syndrome in the upper extremity should be treated with emergent surgery. Miscompartment syndrome in the upper extremity, they felt, represented a different clinical entity where preservation of motor function is of paramount importance. As we know, miscompartment syndrome remains one of the leading causes of medical liability claims. And in 2021, A et al. Looked at a cohort of almost 200,000 patients from the National Trauma Data Bank, 1,200 of which had miscompartment syndrome, and they discussed the risk factors for miscompartment syndrome and tibial shaft fractures. They identified younger age, male sex, substance use, and penetrating trauma, all as factors that have contributed to the misdiagnosis. And recently published literature research also in 2021, they looked at lower extremity compartment syndrome in NFL athletes using the NFL injury surveillance system. They found 22 cases in 21 people. 73% of these occurred secondary to a direct impact to the leg, and concomitant tibial shaft fracture was only found in 9%, so 2 cases. If the case was not associated with a fracture, the average time missed due to injury was 24 days, and all players returned to full participation in the same season. So now we'll move into the surgical treatment options. So as we know, fasciotomy is the accepted treatment for compartment syndrome. In terms of early outcomes after fasciotomy, the mortality rate for patients undergoing calf fasciotomy ranges from 11 to 15%. Major amputations are required in 12 to 21% of limbs. Wound complications occur in a wide range, 4 to 38% of patients, and they're more frequent if the fasciotomy is delayed more than 6 hours compared to early. Renal failure is a rare complication after compartment syndrome unless there's considerable myonecrosis, and neurologic deficits occur in 7 to 36% of limbs and are the most frequent early complications following a forearm fasciotomy. The late outcomes for fasciotomy are determined largely by the functional status of the patient at hospital discharge. So neurologic deficits or amputation in the early postoperative period are harbingers of long-term disability, even in the subset of patients discharged without amputation or neurologic deficits. A fasciotomy predisposes the limb to future problems. So Fitzgerald and colleagues noted that at late follow-up, 77% of fasciotomy sites were associated with impaired sensation at the margins of the wound. 7% had tethered tendons, and 13% had recurrent ulcerations actually at the fasciotomy site. And others have found that a significant portion of patients, up to almost 50%, have clinical evidence of chronic venous insufficiency, and a small subset, about 7.5%, will require late amputation. That's between 30 days and 1 year. A delay or missed compartment syndrome will have devastating consequences for the patient and the limb. It increases the risk of neurologic deficit, amputation, and renal failure. Sheridan and colleagues found that the overall complication rate increased dramatically if fasciotomy was delayed more than 12 hours, about 54%, compared to early fasciotomies at 4.5%. Nearly half of the patients with delayed fasciotomies required amputation, and 92% had significant neuropathy. Not surprisingly, delay of fasciotomy for more than 36 hours almost invariably resulted in amputation. And after 3 to 4 days, compartment release was not found to be indicated given the rate of infection and muscle necrosis being prohibitively high. So there are a few additional options that you can offer patients that are in this unique scenario. So over the last decade, the off-label use of gabapentinoids for the control of acute nociceptive and neuropathic pain has really increased in several countries, including the US, and they're really routinely used for management of postoperative pain, not only to decrease pain, but to decrease opioid use. Gabapentin and Lyrica block voltage-dependent calcium channels. They can provide pain control, though with some prominent side effects that include sedation. Perioperative Lyrica, in most but not all types of surgery, decreases opioid consumption and pain during the first 24 hours. Does have an increase in sedation that can impair mobility and rehab efforts. Gabapentin similarly modestly decreases opioid use, but does not decrease pain scores. Nerve injury in the setting of compartment syndrome appears to be related to compression and subsequent ischemic injury secondary to the ischemic infarction of muscle, nerve, and other tissues. Ischemia of significant magnitude, like what happens in Volkmann's contracture or severe miscompartment syndrome, can produce endonervous scarring over large segments of nerves. And there is very little research on the use of nerve medications for miscompartment syndrome and resultant neuropathy. However, given the success seen in other neuropathies, it appears to not be an unreasonable choice, especially if the sedation risks are thoroughly discussed with the patients. And then steroids. So they have been used in the setting of chronic regional pain syndrome, particularly in the upper extremity after distal radius or forearm injury. Davis and Barrett et al. Recommended Medrol dose packs for CRPS after distal radius fracture as an initial treatment option. However, there is essentially no research evaluating the use of steroids for neuropathic pain after miscompartment syndrome. All right, so just to close out the case, so the patient was seen in late September, about 11 days after his injury. He was having an itching sensation on the bottom of his foot. He did not have any ankle dorsiflexion, but you could feel the tib ant fire. And he was weak, but improving in pretty much every area. He was decreased sensation throughout, but overall could start to feel in those distributions again. And his last visit was in early November, 2 months after his injury. He was now getting stronger everywhere except for his EHL. He had decreased sensation in tibial and DP distributions and had normalized elsewhere and was noted to have a mild steppage gait, but overall was doing better. So this is a really difficult situation to find a patient in. The counseling portion of the visit is perhaps the most important aspect. Patients have a right to understand what they're up against and why you feel that surgery is not the best option for them. Even more importantly, and given that the course is varied after this injury, it can be difficult to counsel patients and frame expectations, as you often do not know what to expect. I found this part of the conversation to be very nuanced with this young kid and his father. The neurologic response after miscompartment syndrome is in no way guaranteed. This patient seems to be experiencing measurable recovery, which is awesome, and maybe in part due to his fitness level and his young age. One could imagine that the same injury in an older patient may not have such a successful outcome, but the variability has to be acknowledged. I do think that the use of Lyrica and gabapentin is reasonable for these patients, especially if they return for follow-up and they're reporting neuropathic symptoms that are kind of in line with the nerves recovering, as our patient did. And I think a steroid dose pack does not really seem necessary, but it may not hurt unless the patient has diabetes or other reasons for avoidance of this medication. So I feel a little bit more strongly about using the anticonvulsant nerve medications than I do about using the Medrol dose pack. Well, any questions about this case?
Lucas had a question in the chat, MJ. I'll just read it. Is there any role for percutaneous fasciotomies and subacute compartment syndrome? Avoid infection associated with open, but have any decompression benefit to the remaining muscle?
I did not see any literature about percutaneous fasciotomies. The literature mostly focused on just keeping the skin closed because the muscle necrosis really becomes unmanageable once you release it. And I think the thought that everyone knows is that you just deal with infection that can lead to amputation after you open it. But I think it's really hard to do good studies on this topic. It's ethically challenging, and also it's not that common of an issue. So maybe there's a role for that, but I couldn't find that in the literature.
The question I've always had is, what's the threshold? What's the time point, at which you don't intervene versus you do intervene? What's your take on that?
A lot of the research talked about 3 to 4 days. I think the timeline of the patient's complaints matter too. So we really hammered with him, like, when did this peak? When were you in the most pain? When did it start to get better? And for him, he had compartment syndrome, I think, the night after this happened. His first presentation to the ED, he was in severe pain. He was having progressively worsening numbness and weakness. And then by the next morning, he had complete numbness and complete foot drop. And so at that point, it was more complete. And he didn't show up to us until 4 days after that. At that point, his kind of status was exactly the same. It hadn't changed. And Dr. Rothberg asked me the same question. He was like, did it improve lately, or has something changed lately, or did it worsen recently? Like, any reason for us to think, oh, it worsened more acutely in the past 24 to 48 hours, maybe we should do something. And that just wasn't there. So I think for me, it's a little bit of the patient course, but it also is like, if you're 3 to 4 days out, you have to really think hard about whether or not it's smart to open things up. And I do think the MRI, if you have access to that and its cost isn't prohibitive, is a reasonable thing, because you can see kind of how extensive is the myonecrosis. For us, we saw a lot of myonecrosis in all the compartments. And so it kind of helped us feel better about not opening that up.
Cool. Justin, Dave, any thoughts on your timing for this? Obviously, Dave, you're involved with this case, but do you guys have a hard threshold for when you're going to open something up?
My thought is it's less about timing and more about the exam. I think that if you have spared function, then a release is appropriate. And if you have a complete loss, that I'll keep them closed. I don't know much about the idea of a percutaneous release. It's kind of an interesting idea. I suppose for me, it would depend on etiology of the compartment syndrome, and whether skin was playing a role, like burns or crushes that might not do a whole lot. But that's sort of the algorithm I use in my head, is based on what the current function is and not really timing.
Yeah, I agree with what Dave was saying. I think the hard part with timing is, I mean, you don't necessarily want to do it from the time of initial injury. But it's kind of hard to know when the compartment syndrome is starting and evolving from, because most patients aren't that great at historians. This guy probably seems like he was, but it's just really hard to know, to have a hard cutoff. It's sometimes fairly obvious if you have these vascular patients that have a dissection that have a missed compartment syndrome or something like that for days. I think leaving those people alone makes plenty of sense. But having a cutoff within 48 hours is sometimes hard to do because the time course is a little uncertain. So a little bit hedgy, but probably somewhere around 48 hours is kind of I think a reasonable cutoff.
Yeah, thanks. I echo those thoughts. I mean, obviously I don't treat lower extremity injuries, but it seems like a difficult decision to make universally. Any other thoughts on this topic? Otherwise, we're exactly on time here to wrap things up. Okay. Thanks a lot, MJ. Nice work.
Thank you, guys.